welcome to the Stronger After Stroke podcast. I'm your host, Rosa Hart, the stroke nurse navigator at Norton Healthcare, and today I'm joined by Dr. Arpita Lakhotia. She is a pediatric neurologist who specializes in stroke, among other things. And I really appreciate you taking the time today to talk to us about how stroke affects children and how they can have their best lives after a stroke.
Thanks for having me here. I'm excited to join you today for this conversation.
It's something that I don't think a lot of people are aware of, but how many children's lives would you say are impacted by stroke?
So yeah, pediatric stroke is often underdiagnosed, like it doesn't get identified quickly. There is about 1 in 100,000 children per year who have pediatric stroke. And if we think of neonatal stroke, meaning babies under 28 days of life having stroke, that's even higher. It's about 1 in 1,000 live births.
1 in 1,000?
Mhm.
That is a lot more frequent. I believe I heard that it's in the top 10 causes of death in children. Is that right?
Childhood stroke, actually, I don't know the answer to that. We might have to do this
Well,
again.
okay. So I recently attended the International Stroke Conference for the American Heart Association and learned that pediatric stroke is in the top 10 leading causes of death for children. So the work that you are doing is so important, both to prevent them from passing away, but also to help them optimize to have the best quality of life after. And I'm
No more.
excited to hear from you about neuroplasticity and the role that plays with children and maybe how that's different from adults.
Yeah, of course. I always tell my patients that no one should have a stroke, but if you are going to have a stroke, the younger you are, the better it is, because the brain is so great at neuroplasticity and getting those connections made, especially over time as they do therapy, rehab. We can see such great outcomes, especially in neonatal strokes. So, babies who have strokes, depending on, again, some of it depends on what caused the stroke and how big it was. But with good therapies, with good rehab, we can see really great outcomes, which you and I might not have if we had a stroke.
Right. Yeah. And so that can be an encouraging thing to hear today. So, what are the causes of strokes in children that are different from what might cause a stroke in an adult?
Yeah, stroke in kids is very different from what causes stroke in adults. None of the hyperlipidemia and atherosclerosis. So the big causes that we think of in pediatric stroke, congenital heart disease,
Mm.
vasculopathies or blood vessel disorders, blood clotting disorders or thrombophilias, head and neck infections and trauma tend to be one. Sickle cell disease is a big cause. Um, and then a lot of genetic conditions can increase the risk for stroke in kids.
And you said head and neck infections. Does that include like viral infections?
Absolutely, absolutely. There's actually a higher risk for kids having strokes after a minor viral infection. There was some studies done for that through the International Pediatric Stroke Study years ago that showed that that risk is higher for
Why
having
is that? Is that due to inflammation?
just the way that the inflammation cascade is in kids and the way that their vessels respond to those infections.
Wow. So, if a child is showing signs of a stroke, normally we use BFAST to identify. So, I'm going to go over that real quick. And then I'd love for you to point out anything additional or different from what we look for in adults versus kids. So, we use BFAST to recognize signs of a stroke at any age. B is for balance, a sudden change in balance. E is for eyes, a sudden change in vision. F is for face, where one side of the face is drooping. A is for arms, where one arm is weaker than the other. S is for speech, like slurred speech. And T is for time, where time saved is brain saved. Or you could say it's for terrible headache, because if you
Oh,
hear,
okay. That's the first time I'm hearing about that. Okay.
well, because we would say like a
Yes.
sudden onset
Yeah.
of the worst headache of
Yep.
your life, usually if it's accompanied by feeling like you hear a thunderclap in your head like this, followed by the worst headache of your life, that could be a sign of a
Yep.
hemorrhagic
Sure.
stroke. So now what might be different for children and how they present?
Yes, so for a pediatric stroke, the BFAST acronym will still apply, but there are a few other things that get added on that usually you don't think of as strokes. So sometimes they can present with a first time focal seizure, meaning a seizure on one side of the body, which is not caused by anything that we know of and they don't have a diagnosis of epilepsy, and then we do imaging and we find that it was due to a stroke. The other thing is really bad headaches, especially with vomiting, which I guess you can
Yeah.
put that in your thunderclap headache. But also, we know that kids who have, say, venous thrombosis, so clots in their blood vessels, they can have bad headache, progressively getting bad
Yeah.
headache and vomiting. So that's one other thing to think of. And then sometimes confusion can be something, which is a really broad term for kids. But kids are kids. Sometimes, depending on their age, you might never get a history. You might not get that exam that you're hoping for. So just keeping that confusion vague out there is one other thing to think of. When we think of neonatal stroke, meaning babies who have strokes, the signs are very, very different. So, a lot of times we'll discover that a baby has had a stroke based on if they start having one sided seizures in the hospital, they start having breathing issues or seizures on one side of the body. That would be one. A lot of times they might not even get diagnosed with stroke. Even if they've had it as a baby, they might not get diagnosed because you don't need much to be a baby. So, if
True.
you're moving around, it's fine. And then as those babies get older, sometimes they might have early handedness. So they might start using one hand over the other, and the side that's affected, they might keep that in a fist, and they might notice that they're dragging that one leg. So that could be a sign. We'll see some kids for that, for evaluation for that, and they have delays, developmental delays. We see them, and then once we find this, we're like, okay, it's probably a stroke. And the stroke probably happened way early in the process.
Let me go back to what you were saying about focal seizures, because I think the most common perception about seizures is you see somebody twitching, and the question is, do you get a spoon or not to put in their mouth,
No,
right?
no spoon,
No
no
spoon.
spoon, nothing in
Rule
the
of
mouth,
thumb, don't
nothing
put
in.
anything in their mouth. But if you're talking, you said focal seizure on one side of the body. Now, what I'm often educating people about is looking for that one-sided weakness in adults.
Mhm.
So are you saying they will have like a lot of twitching on one side of the body with that focal seizure?
It could start off as that, but a focal seizure can also generalize, meaning it involves the whole body and it becomes kind of a grand mal seizure. But if it is truly starting on that one side, eyes are stuck to one side,
Mm.
that could be a sign of that the kid had a stroke and that caused the seizure. And in some studies, up to 20% is the number that's seen of a seizure as a presenting feature.
And when you say eyes are stuck to one side, do you mean that during the episode, their eyes are deviated to one side, but they come back to normal when the seizure's over?
Typically, yes,
Okay.
yes, yes. And actually, that brings up a good point. The other thing, which again, uh, outside of the healthcare setting, people might not think of is after the seizure stops, it's also if they have paralysis on one side of the body, that could be a sign that the seizure was focal. And then we would want to evaluate that.
And is that, I know I've heard, I don't work specifically in epilepsy, but I believe I remember them talking about the post-ictal
Mhm.
phase. So would this be just a certain amount of time of weakness on one side after, and then it resolves
That
and
is
they get their function back?
that's correct. So yes, it's called Todd's paralysis.
Todd's paralysis?
Yes, that's just a someone named Todd's
Somebody named Todd.
described it, and that's who it got named after. But it is transient paralysis, meaning paralysis for a short period of time after a seizure. Now, Todd's paralysis is not specific for a stroke. Someone having that doesn't say that, oh, they had a stroke. That just tells you that the seizure came from one part of the brain. And if they don't have a history of previous seizures, then we start thinking of, okay, stroke is one possibility, but there's many other possibilities of what could be going on.
And is the way to identify that with an MRI of their brain?
For a pediatric stroke, yes. So, like in adults, a lot of times we'll get a CAT scan and it either shows blood and you know it's a hemorrhagic stroke, or it doesn't show anything. And we say, okay, it must be an ischemic stroke, and then do all the treatments. In kids, it's a little bit different because there are so many mimickers of stroke.
Yeah.
In some studies, up to 60% of kids that come in with stroke symptoms actually have some mimicker. So in kids, the recommendation is before saying that, oh, someone had a ischemic stroke, we want to get an MRI and MRA to prove that that's what happened.
Yes. Because then you're looking at different interventions that might be appropriate for them. Do you give T and K or TPA, the clot busting medications for children as well?
So in children, research is lacking. And if you went to the ISC, there was a lot about probably the new guidelines that came out.
Yeah.
And for the first time, they included pediatric stroke. But
Finally.
yes, finally. But when you look at the guidelines, a lot of it is basically for the pediatric part saying that we don't know much. We need more research. So there is not a lot of research for use of some of these clot busting medicines or thrombectomy in pediatrics, but more and more centers are using it. So even in the guidelines, TNK has no evidence for pediatrics yet. Some centers are trying it, but it's not backed up by data yet. But for TPA, the clot busting medicine, it is something that can be considered if a child presents with clear symptoms. You get an MRI that shows a stroke, and it is within 4.5 hours, and the deficits are disabling. It is something that can be used. The data for that is not the greatest, but it is a reasonable thing to use. And same thing for endovascular thrombectomy, that if there is a large vessel occlusion and we know that there is brain that can be saved, it is something that can be used. And it is in the guidelines this time around.
Yay.
But even the guidelines say the data is not there. We need more research for that.
Yeah. What would it take to get that research or to participate in that research to build it?
Yep. So that research is happening. It's been decades, it's been happening. And it's kind of a cool historical thing. Initially, there was a group that got together of pediatric stroke enthusiasts, basically really smart people who want to treat pediatric stroke. They got together, made a group called the IPSS, International Pediatric Stroke Study. The IPSS decided to do, they got many centers together and decided to do a trial to say, can TPA be used in kids? Is it safe and effective? So it was called the TIPS trial, and this was a long time ago. And to be able to do TPA, you need to identify stroke first.
Right.
So because of that, all these stroke centers emerged across the country where every hospital got their own stroke protocol for pediatrics going. And the TIPS trial had actually, they had to shut it down because they could not recruit enough kids in time.
Mm.
Again, because they don't get diagnosed early, so then you can't really treat if that's not in time. Um, but the IPSS is basically a multi-center, multinational group. And I think I don't know what number it is now, but I know that they have over 50 centers, I think, at this point, that are involved in research. We're a part of that also.
Oh, great.
And we gather that data and submit it to a central registry so that we can do more research in terms of what causes pediatric stroke, how do we treat it, what are the best practices. So any study that you see, actually not any, but like majority of the studies that you see that are big for pediatric stroke, you'll see that it is through that IPSS group.
That's
So
fantastic.
people are working hard to try to
Yes.
find something. They just don't have those answers yet.
Yeah, that's understandable. But I'm really glad to hear that you and the others here at Norton Children's are participating in that and that we are getting closer day by day. So, Dr. Lakhotia, for your patients who you are seeing after they've had a stroke,
Mhm.
them, their parents, or whoever their caregiver is, we talked a little bit about neuroplasticity. What do you usually tell them in those follow up appointments to help them have their best quality of life?
A lot of it depends on how old the child is when the stroke happened, what caused the stroke, and how big and where the stroke is, right? Brain is real estate.
Hmm.
So even a tiny stroke in an area in the brainstem can cause major deficits, but you can have a big stroke, say, in the right parietal lobe and be fine. So a lot of it depends on where the stroke happened. So some of our conversations are led by that. Some of the conversations are also led by how young or old the kid is when it happened. But the one thing across the board that is important is rehab and therapy. The more therapy that we do, the better quality therapy that we do, the better the outcomes are. That's really the best thing that you can do after a stroke in a pediatric patient. Depending on how big the stroke is or how major the deficits are, really, a lot of times patients will go from the hospital to inpatient rehab. We have an excellent rehab here, the Fraser Rehab. They have an
Hmm.
excellent pediatric team.
Oh, they do?
Yes, yes. They take them for inpatient rehab. And when I see those kids a lot of times in clinic, you can't believe that they've had such a major deficit. Like
Wow.
kids who were, we've had some kids recently with a spinal cord stroke, actually,
Yeah.
and they were quadriplegic with a breathing tube and everything, and they're walking.
That's
Yeah.
amazing. Not
So
a breathing tube anymore either, right?
not a breathing tube.
Because you can walk while
Yes,
intubated,
yeah,
as we have seen.
yes.
Um, so that is just incredibly encouraging. Are there insurance coverages for things like that, or are there very many barriers to children being able to access those kind of rehabilitation therapies?
There's always barriers with insurance.
Yeah.
But in general, it is one of those things that, again, if the deficits are bad enough and you document that and you tell insurance that this is what they need inpatient rehab for, or this is what they need outpatient rehab for, they will cover it. We do run into issues with sometimes getting more long term outpatient therapy covered or getting adaptive equipment or bracing and all of those covered. But over time, again, fighting with insurance, we're used to that.
Right.
So,
And we're in Kentucky, but we have listeners in almost 100 countries now. Navigating a healthcare system wherever you are can be really tricky. If they don't have a stroke specific navigator nurse person, who would you refer people to look to for help in navigating healthcare with a diagnosis like pediatric stroke?
so there are some good advocacy organizations that I'll often refer patients to. IPSO, International Pediatric Stroke Organization, is one of them.
Okay.
They came out through the IPSS, but then some of the other good ones are IAPS, which is, I think it stands for International Alliance for Pediatric Stroke,
Okay.
and then CHASA, which is Childhood Hemiplegia and Stroke Association. Maybe I got one or two words
Okay.
messed up, but if you look up CHASA or IAPS, they've got a lot of resources on pediatric stroke in terms of what to expect after a stroke, how to navigate challenges, what are some good resources like people can read and learn, and even build a community.
Hmm.
So connecting with other families who have kids with similar strokes or similar
Yeah.
deficits.
It can mean a lot to know you're not the only one going through this and to learn from
Yeah.
other parents or caregivers, like what worked for
Yeah.
them.
Because that often happens is whenever someone finds out that their child has had a stroke, they're like, "Oh, what do you mean? We didn't know kids could have stroke." So
Yeah.
that aspect of community is always helpful. That, oh, there are other kids who've had this happen to them, and this is how they're doing.
Yeah. And it is different from other neurological conditions that are chronic and degenerative. Like this is an injury, like a brain injury or the spinal cord stroke injury,
Yeah,
like a
yeah,
spine injury,
uh-huh.
and you can recover from it. It doesn't mean that your body's just going to degrade from there
Hmm.
on. You can get stronger after the stroke.
Yep, absolutely.
It's
Just
like
like,
the
like the
name
name
of
of the
the podcast,
podcast.
just like the
Okay.
name of the podcast.
Yeah.
Which is why we're talking about it. So are there things like support groups that you know of that they can join in on? I know the American
The
Heart Association has like a caregiver portal. It's like a message board or Reddit
I
for
see. Oh, okay.
caregivers. So I'm sure they could like create a thread if there isn't already one for
Pediatric.
pediatric
Yeah, I
parents.
I don't know if it exists like a pediatric one for with the American Heart Association, but like CHASA and IAPS have good communities that you can connect with. They
Good.
do things like summer camps and they
What?
do like little meetings and everything where kids can go. So they do have a lot of resources there. It's worth checking out.
That's cool. And maybe even
Yeah.
respite services for the parents, you think?
I don't know about that.
Okay.
I don't know about that, but I know that depending on how severe the deficits are, parents through Medicaid here can get respite services also.
Yes, I know we've sent a lot of people through KIPTA, especially if it's grandparents caring for grandchildren.
Mhm.
KIPTA has a lot of resources for and helping people get set up with a waiver program to get paid to be a
Yep.
caregiver for their child. So you can look into whether or not that's an option in your state as well. The thing with stroke at any age is nobody was planning for this. It's not like we did
Yep.
a genetic test and know we have this to look forward to in 30 years and can plan for it. It happens and then it changes your life.
Mhm.
So, are there any other supportive resources you want to make sure that all of them know about?
I am trying to think. I think having a social worker in clinic is always helpful for this. We don't have a nurse navigator in our stroke clinic, but our social workers are great and they can help out, especially with navigating Medicaid, getting those waivers if things are more disabling. Aside from that, I'm trying to think, and this could be a whole different conversation. So
Yeah.
I don't even know if I want to open this box, but like cerebral palsy, right? So, what is the relationship between stroke and cerebral palsy?
Yeah.
Do I want to talk about that here?
Yes.
Okay. So, a lot of times, parents, especially if the stroke happens really early as a baby, we might talk about, okay, they're showing signs of cerebral palsy. And all cerebral palsy means is that some injury happened to the developing brain. It is causing a motor deficit and it is not progressive, meaning it's not getting worse.
Mm,
So if you think about it,
yeah,
if someone has a stroke as a baby
yeah,
that's affecting their motor function, they could develop cerebral palsy over time. And usually, when I say the term cerebral palsy, majority of the people think someone with a breathing tube, a feeding tube, who's not walking, not doing anything.
right.
It's an umbrella term. It's
Oh,
everything. So in popular media, you see that patient who has seizures all the time, not walking, not talking, all the things. But you can be someone who's in med school and has a little limp when they walk or a
yeah.
little drawl when they talk. It can be a spectrum of everything. So
Wow.
a lot of times when we talk about, especially some of these babies who've had strokes, we'll start talking about cerebral palsy because you'd asked about insurance. And the way insurance is, I could say all the words in my note about had a stroke secondary to this, causing this, and they might not approve things. But if I say has cerebral palsy secondary to stroke, magically doors open up and things get
Wow.
covered. So if your doctor is going to talk about cerebral palsy, take it. Because it really does not mean anything is getting worse or that we're giving a new diagnosis. All it means is we're putting a name to that combination of symptoms that you have after a stroke, meaning that spasticity, that weakness, and it's not going to get worse.
And a name that can open up more resources and support
Yes.
because that's recognized as
Yes, as a thing that needs support.
that's fantastic.
Yeah.
See, I learned so much from you already. I didn't even know to ask about that. So
Okay,
thank
there
you.
you go.
Yeah. Wow. Because I kind of had it in my idea as like more of an anoxic brain injury, but I guess
And
like
that's
what
yeah,
else?
and that's one of the
Yeah.
reasons. So CP is, again, that's the whole different conversation.
Yeah.
That's why I don't I don't know if I wanted to go there. But there's so many reasons why someone can have CP.
Yeah.
But perinatal stroke around the time of birth or before birth or right after birth, even up to 2 years, is a risk factor for cerebral palsy. So if after stroke, if you're getting a diagnosis of CP, it's fine. It doesn't mean that anything bad happened or anything changed over time. All that means is that we're giving you a name to put all those symptoms together.
That is
Yeah.
fantastic. Well, this has been incredibly illuminating, and I hope also really encouraging for any of our stroke survivors or caregivers who are listening that you are not alone. That this happens to a lot of people, and apparently it might happen under different
Yeah.
names than you might have expected. But I hope that they're able to connect with other people who can relate and to resources that can provide them with ways to optimize their life and be stronger after that stroke, after listening to what you shared with us today.
Yeah.
So
Hopefully
thank
that was
you.
helpful.
I think so. I
Okay.
know I'm smarter for it
There you
just
go.
listening to you. But so if you have learned something from this episode, please leave us a comment wherever you're listening. If it's on Spotify or Apple Podcasts, or if you're watching on YouTube, definitely tell us what you learned. Tell us what you'd like to know more about. I will try to list the resources that she mentioned in the show notes so you can go directly to them. But if you know of other resources that we left out, please let us know because we want to share and we want to make sure that everybody has access to what's available to them. And if not, maybe duplicate things that are working for
For
one group.
hmm
Let's share it into another area, right? So that's the beauty of the internet. So if you are listening to this, please like, subscribe, stay tuned for the next episode, and I will see you there.